Sudesh.
Dr. Sudesh, nice
Hi, Kimber. Nice to meet you.
Nice to meet you.
Yeah.
Thank you for joining us this
Yes,
evening.
yes, of course. Waiting for your lecture.
I am hoping that it is. I have a lecture prepared, but I am hoping that it can also be a conversation.
Definitely.
Yes, yes, yes. That would be nice. That would be nice.
Ma'am, do you have any PPT to share? Do you have any presentation?
I do. Shall we go ahead and try it now before everyone?
Sure. Yeah. Okay. That will be great.
Okay.
Who is handling the technical thing? Masha? Okay, right.
Ma'am, are you able to share?
I am working on it. I usually do not use Google.
Oh.
And so my system is not set up for it.
All right. There is just the small arrow near to that video icon. If you could just click that on your screen. At the bottom, it will show share screen.
Yes, that's what I tried to do before. And it doesn't seem to like that idea.
All right. Do you want to share it from our side? If you could share the PPT. So you can just click.
Let's see. That might be the better plan. It actually is not in, let's see, I will share it as a PDF. Because I don't use PowerPoint.
No.
So yes, I use something called Keynote, which is Mac friendly.
Oh, okay.
So I'm printing it as just a PDF. I wish I could just send this because that would be so much easier for everybody. Yeah, it is not letting me share at all.
Oh. Could you mail me then?
Yes, I'm gonna email it to you. Okay, I just mailed it. Let's see if you get it.
1 second. Not yet. haven't yet received. Yeah, got it, got it. One sec.
I apologize. I'm not quite sure why my computer is unwilling to share the screen via Google, but
That's okay.
those technical details sometimes.
That's fine. We can share from our side. No issues.
Just a second. Um, I'll just share.
Lovely.
Able to see?
Yes. I'm sorry. That means you're going to have to be in charge of advancing the slides.
Fine, no worries. I'll be here.
I appreciate it.
Good evening, everyone. I hope everybody has joined. Are we waiting for more people?
Um, we can
Great.
slowly start, Anushka.
We can start.
It's
Okay,
it's 7.
amazing. Good evening and good morning, ma'am. It gives me immense pleasure to welcome you all to the first session of Transdisciplinary Perspectives on Health lecture series hosted by the School of Psychological Sciences, Christ University. I'd like to call upon Dr. Manjusha ma'am to introduce the speaker and the session.
Thank you, Anushka. Good evening, everyone, and good morning, Professor Cameron Hay. It's my absolute pleasure to introduce our speaker for the day, Professor Cameron Hay. Ma'am is professor and chair of Department of Anthropology at Miami University, where she also serves as coordinator of the Global Health Studies minor. She's a distinguished cultural anthropologist and specializes in medical and psychological anthropology with field work experience in Indonesia and ongoing research in United States, Zambia, and India. Her work explores how people understand, communicate about, and manage health concerns in everyday life, a theme that lies at the very heart of this lecture series. She's renowned author of various publications, as well as her articles have been published in many national and international journals. Beyond her scholarly contributions, Professor Hay directs Global Health Research Innovation Center at Miami University and leads a truly transdisciplinary global health program that addresses a wide range of pressing health challenges, both locally and globally. Her commitment to collaborative and integrative approaches makes her an inspiration to this series and for many of us who are interested in health and social sciences. From the very inception of this transdisciplinary perspectives on health lecture series, Dr. Hay has been a generous and steady guiding force for us, offering mentorship, encouragement, and thoughtful insight. I'm personally honored and delighted to welcome her as the inaugural speaker for today. We are also privileged to have with us our Dean Dr. Surekha and our HOD Dr. Sudesh, Dr. Elizabeth, and our former Dean Dr. Tony, along with many other faculty members and students from Christ University and outside. Um, I welcome each one of you very warmly to the session. And maybe the next 1.5 hours be a meaningful and enriching learning experience for all of us. So, without further delay, please join me in warmly welcoming our Professor Cameron Hay as she speaks on the topic Rethinking Agency in Chronic Illness. We are eagerly waiting for it, ma'am, to know about a holistic approach to health considering the social, political, and historical context of illness. We look forward to it. Welcome to you once more, and over to you, ma'am.
Dr. Marusha, thank you so much. That's a very generous introduction. And I do hope I live up to all of the expectations you just outlined. Let me start by saying how excited I am to be here and with this inaugural and very innovative Transdisciplinary Perspectives on Health lecture series that is international in scope. And I really appreciate Dr. Manusha's visit last year, where we began to ideate this lecture series. It was initially her idea, and she helped me think through it and think through how we at Miami University might be able to contribute. I will say that just last week, Vice Chancellor Father Josie and Father Thomas were at Miami University's campus. We are at Miami about to celebrate our 10th anniversary of collaborations with Christ University. And it was started all those many years ago with conversations between Dr. Vaishali Raval as well as Dr. Baju Gopal. And from that, it has flourished in large part because of the support of Dr. Tony Sam and Dr. Elizabeth and Anush Kamir was at Miami last year and gave a guest lecture in my global health class, right? So our lives and our scholarship has been intersecting for almost 10 years now. And I am so excited about this lecture series that is facilitating a continuation of those conversations. If you would please advance to the next slides. There we go. So that's just my introductory. There's the title. Let's go on to the next one. And I do apologize for those of you who just joined. For some reason, my computer was not being friendly in terms of sharing my slides. So let me start here. And I know that many of you have had the experience of studying anthropology, or at least reading about anthropology. But as I am an anthropologist, and because this is an educational forum, I wanted to spend just a couple of slides talking about what anthropology is. Anthropology, as it is practiced in the United States, is very simply the study of humans. And when I tell that to prospective students and their parents, they are completely bewildered, because we all studied humans, whether we are looking at psychology or sociology or, right? So what's this anthropology business? I am a cultural and social anthropologist. So that means I look at our cultural and social ways of being in the world. Next slide, please. Oh dear. Okay, let's go back to the last slide. So when I converted this into a PDF so I could share it, not everything came through. Oh well, I'll walk you through the rest of it. So anthropology is not just one subfield. It is also biological anthropology, where we study the human physiology, its origins, primatology, and diseases, which is relevant to our discussion today. It is also linguistic anthropology, how people communicate, and the scopes of those communications, verbal and nonverbal. It is also archaeology, the stuff humans leave behind and what we can learn from the stuff humans leave behind. And my own particular sub area is medical and psychological anthropology, which in many ways bridges multiple of these disciplines. So I draw on linguistic anthropology, social cultural anthropology, biological anthropology, because in order to understand how people experience disease, how they experience the emotions that are associated with disease, I needed to be able to draw on multiple perspectives. So anthropology is really, I like to think of it as a holistic discipline. And it's one that allows me to partner across multiple other disciplines, including with fabulous psychology faculty and colleagues like those on this call. Okay, now please advance. You've already gone over, oh, that slide, please. Nope, the next one up. Not this one, the one you just went past. That one, yes, thank you. You gave a brief introduction of me and who I am. So I won't go over the part in the left, though I will highlight a photo just taken a couple of years ago in 2023 with Dr. Gopal and Dr. Thomas. So wonderful, as always, to be on Christ's campus. On the right, you will see recent and ongoing research projects that I am doing. So one on environmental health and how environmental contamination, in this case, lead contamination in Zambia, affects long-term health outcomes, and how people understand what can be done to mitigate those. Project, the two bottom ones are projects on substance use disorder and its recovery, as well as neonatal opioid withdrawal syndrome. So what happens to the babies that are born to mothers who are currently within various stages of addiction or withdrawal. And then if you scroll down to the next one, I want to highlight the three in the middle. So rheumatic diseases, sickle cell disease, SCD, and EDS, Ehlers-Danlos syndrome. These are all chronic pain conditions. And if I had to point to sort of the abiding research interest that has been with me for over 20 years now, it's been trying to better understand pain and chronic pain conditions and how those impact people's lives, how those impact relationships between doctors and patients, and what can be done to improve people's experience of these pain conditions, even if we do not yet have biological ways of mitigating the pain, the chronic pain. Next slide, please. Oh, well, and here too is another one of the bullets that didn't quite transfer. So Dr. Manusha outlined 5 different goals for our project here as part of the Transdisciplinary lecture series. Critical reflexivity, especially looking at potential biases within health contexts, being critical about thinking through these different ways of thinking and those biases, as well as how do we do this collaboratively? How do we have real conversations? Looking at real world interventions, deepening our insights into critical health topics. And because the slide doesn't have it, I'm having trouble seeing it. There we go. And a transdisciplinary mindset. So in this talk today, on the last slide, I highlighted the 2 papers I'm going to be referencing the most. Those 2 at the bottom. One was written in 2010, so Suffering in a Productive World, Chronic Illness, Disability, and the Space Beyond Agency, from which the title for today's talk emerges, as well as a more recent article by a former student who is now a physician, Mitchell Singstock, myself, and a patient. This is a piece that's actually co-authored with the patient about which tells his story, Pain and the Arcs of Suffering and Well-Being. So I'm going to highlight those 2, and these are the topics that I'll be talking about today. So we'll be starting with pain, then looking at cultural models and agency, the suffering response, and then, of all things, I will be talking about spoons. Because, we have to have something fun at the end of a lecture this late in the evening for you. Okay, please go ahead. Now, at this point, I would like to be quiet for a minute and ask you all to take out a scrap piece of paper. We're not collecting these. No one else is going to see these but you, but I would like you to start listing. Just make a list of all of your activities that you have done so far today. And you'll see on the screen the activities for my list. So I woke up and I went downstairs. I made coffee. I worked on the computer. I went downstairs for 10 minutes of exercise. I went upstairs to eat breakfast, and then I went upstairs again. We live on 3 different floors, so I'm constantly going up and downstairs. To shower and dress, I went downstairs. I drove to the office. I walked to my office after parking. I worked on the computer, and now I am meeting all of you. So if you just take a minute and make your own list for today. Can you give me some indication when you all are wrapping up your list? I love all the thumbs up. This is very fun. Okay, please hold on to that list. We're going to be coming back to it at the end of my sort of formal comments today. And before I go any further, let's go on to the next slide. Before I go in, this slide's perfect. Before I go any further, let me say I'm really hoping that this is a conversation. So please do not hesitate to interrupt, to ask questions. I really would like to have opportunities to engage and see how you're responding to things. So if you have questions or comments as we go along, please don't hesitate. Now, I'd like to invite you to think about the last time you were in significant pain. I want you to sort of sit with that space, whether it was a broken bone or a migraine or a bronchitis and that horrible, painful feeling we feel when we're coughing and we have bronchitis. Whatever it might have been, I want you to think about that pain and how you felt in that moment of pain. Now I have a question for you. So in those contexts of pain, to what extent are you thinking about what comes next? What are your thoughts when you're sitting with that kind of pain? Yes, thank you. Right? You want the pain to go away. I assume many of you on the call would agree. Yes. When is it going to end? I want it to go away and I want it to end so that I can get on with my life. Right? Pain interrupts us. It stops what we're doing. And we just want it to go away so we can get back to things. How many days will I lose this time? Oh, that's a fascinating question. And it's something you want to solve. How many days will I lose? Isn't that interesting? That we think of days living with pain as lost days? This again. It's back. Yeah. These are great comments. So if we look at one of the official definitions of pain, and I'm going to read it to you, it's from the International Association for the Study of Pain, and it defines pain as an unpleasant, go ahead and stop there, an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential damage. So that definition of pain that I just read to you is unpleasant sense and emotional experience that is either signaling real or potential damage. But that definition doesn't capture what you all just told me, right? When is this going to end? How many days am I going to lose with this? How can we solve it? It's a very bland definition. Whereas if we look at David Morris's work, he argues that pain, chronic pain, is usually, and I'm quoting, usually an unrelieved disaster for the person that suffers it. So if we talk about pain as something we know is transitory, it's something you live with, you worry about, you want to end. But what if pain isn't that? What if pain moves into your house and doesn't go away? What if pain is like one person commented, this again? They're crawling under that pain is crawling under your skin. It becomes, as one of my collaborators put it, my me. My me is a me constantly in pain. My me is a me that I don't remember a day when I was living without pain, which is just the reverse of the kinds of experiences of pain that we were all just commenting on, right? What if pain becomes so much part of one's world, one's being? Are all the days lost? This is the problem of chronic pain. Scroll on to the next slide, please. So the two papers I'm talking about, as well as a new paper that I'm working on that will show up sort of at the end of this talk, are based on multiple projects. The largest was a project that I completed at UCLA. It involved tracking patients during all of their appointments with physicians for 3 years in a rheumatology clinic, and that had 132 patients, and that's really the one that I drew on the data for, but it also included a multiple sclerosis clinic. So I'm really leaning into the rheumatology data for my talk today, as well as multiple smaller projects that I have been doing over the years with people with psoriatic arthritis, rheumatoid arthritis, and scleroderma primarily. And these are rough numbers. That's why you have the approximation. But what I will be talking about in terms of patient experiences, I have had multiple patients contact me and say, I saw that you were doing a new study. I want to be part of it because you get us. You get what this experience is about. And it's because they've read some of my previous writing. So I work very hard in what I do to make sure that while I am talking to physicians and while I am talking to other scholars, this is that transdisciplinary work, I am also trying to talk to patients to make sure that I really am getting close to getting right my descriptions of what it's like to be alive with these chronic diseases. Okay, please scroll down. All right, so what are these chronic diseases? I hope none of you have them. I hope none of you have family members that have any of the diseases that I am going to talk about today. But I want to give you some sort of sense of what these diseases look like. And if you could scroll down just a little bit more so that you can capture the whole slide. There we go. Thank you. So all of the diseases I'm talking about are autoimmune rheumatic diseases. So they are non-communicable diseases. They are all characterized by chronic pain, loss of function, flares, which means that it's very hard to schedule anything because one day you'll be fine and the next day you can't get out of bed. That's what a flare will do to someone. Fatigue that is incapacitating, constant uncertainty, including not only about planning one's schedule, but when one's drugs are going to stop working. And they do with these diseases. So they will work for a while and then they no longer are functioning. And so a physician has to look and try to find a new disease that might improve well-being. And all of them have systemic impact. And by that, I mean, they will affect, they can affect internal organs. So digestive system, respiratory system, cardiac system, neurological system, right? So these are really systemic diseases and they impact approximately 4% of the world's population globally if we look at these autoimmune rheumatic diseases. So within this, there is scleroderma, characterized by the hardening of organs. And you'll notice the onset is young to middle adulthood. Predominantly female. Okay, next slide. I think we're going to get the next disease. Yep, rheumatoid arthritis. This is the most common of the diseases that I will be talking about today. It's bilateral, so and the bilateralness distinguishes it from psoriatic arthritis. So what happens on the left side of the body also tends to happen on the right side of the body. Joint stiffness, pain, and swelling. Sometimes you can see these diseases, sometimes you can't. Go on to the next slide, please. Psoriatic arthritis. Swelling of the digits. It is not bilateral. Usually one side of the body is affected more than another side of the body. And one more, please. One more slide. And systemic lupus erythematosus, so characterized by chronic fatigue, skin rashes, usually a butterfly rash on the cheeks is the first telltale sign of lupus and hair loss. Some of these are easier to diagnose than others. Scleroderma tends to be very hard to diagnose, as does psoriatic arthritis, lupus because of the butterfly rash that's very common, and rheumatoid arthritis, which is better known than the others, tend to be more easy to diagnose. Let me pause there. Are there any questions about these diseases? The big takeaway from these is every single one of them, people can live with chronic pain. That's not to say that they can't be controlled. So some of these diseases, we have very good biologics, as well as more garden variety medications like prednisone that can really tamp down the flares and keep the pain under control. The people that I will be talking about today, the cases I will be talking about, are of people's experiences with these diseases that are not being controlled. And these are very complicated diseases. They also often have comorbidities, which makes management quite challenging. Okay, next slide. Prevalence in India, just in case you're curious, for rheumatoid arthritis and lupus, looks like it is, rheumatoid arthritis in particular, looks like it is higher than, it might be higher than the world average, which I was giving those thresholds in the last slide. And lupus is about on average. One of the things that's striking, is, at least to me, is that there seems to be a dearth of research that is being conducted with rheumatologists and their patients in India. And so for those of you who are looking for research topics, rheumatologists are amazing to partner with. And I highly recommend you think about initiating some research that is looking into these rheumatic diseases, because what I will be talking about today is experiences defined within the cultural context of the US, which may not, and it would be fascinating to find out, does not translate to the experiences of people in India. Okay, next slide, please. So as we've talked about, these painful conditions feel like an ontological assault. And if I developed the term ontological assault, drawing heavily on Linda Garrow, a medical anthropologist, who talks about disease being an ontological challenge to self. And Steve Parrish, whose work talks about conditions that assault our capacity to live. It crashes into our lives, forcing us into struggles to adapt and raising questions about self and existence in the process. So why does self become wrapped up in pain? Why does self become wrapped up in these chronic conditions? It becomes wrapped up in these chronic conditions because it is so omnipresent. It is an assault. You can't escape it. If you are in pain, you're just thinking, when is this going to end so I can get on with my days, so I can get on with my life? But if the pain doesn't end, then what? How does one keep moving forward with pain that doesn't end? Next slide. So I'm going to give you a couple of quotes from patients that I've worked with. This is Patricia. She was diagnosed with scleroderma, and she was diagnosed quickly. She was diagnosed in the span of 1 year. Most people who, most of the people that I've talked with who have scleroderma can take anywhere up to about 6 to 8 years to get a diagnosis. So that's 6 to 8 years of living with pain, of watching your skin harden and no longer being able to say, open your hands. It hardens into a fist, or it can, and not knowing what's going on and not finding anyone who can help you. So Patricia described it as, I feel horrible every day. I haven't had a good day in like a year. You feel like you have the flu. I do. Like I have the flu all the time. It's a struggle. Every day is a different day. It's a different struggle and a different obstacle. And when I say it's an assault, these diseases can a person can go from feeling normal to being bedridden within the span of about a month. Right? These diseases can, from a subjective point of view, feel like they're coming out of the blue. No preparation for them. You might not have a family member who has them. They're just there. Okay, next slide. And this is Sarah. So Sarah has lupus. During flares, she said, I can't even get out of bed. I feel so helpless. Sometimes I even feel hopeless. I have to rely on others for everything. 20 to 25 days a month, I can't even put away the dishes. That's how weak I am. The days are long and I can't do anything. Many of you I know on this call are psychologists or clinical psychologists or psychologists in training, and I want you to tune into her phrase, or consider tuning into her phrase of, sometimes I even feel hopeless. I don't have a solution for hopelessness, but that's why I partner with people like you who are brilliant, who might, right? And this is a very common response for people who have uncontrolled chronic autoimmune diseases, right? The uncontrolled pain can very quickly turn to feelings of hopelessness. And in my sample, that hopelessness is related to not being able to do anything. Next slide, please. Pain is also often invisible. And I'll talk about this a little bit more in a minute, but the images I showed you of these diseases, I was highlighting things you could see, right? Deformities in the hands, rashes. I didn't talk about ankylosing spondylitis, but one can see some of the curvatures in the back, sometimes that are associated with ankylosing spondylitis, and the limbs and so forth. Pain isn't always visible. These diseases are often invisible. Even the hardening of the skin that is evident in scleroderma might not be evident to someone with an uneducated eye who doesn't know what scleroderma is and has never seen it before. It's very easy to, as Bob Edgerton once put it, pass as normal because one looks normal most of the time with these chronic pain disorders. But that normal appearance can be useful to someone who is trying to pass, who is trying to get through their day, but it also can be harmful. It has a flip side to it. And I'll talk about that in a minute. Okay, next slide, please. So those are pain. This is wrapping up our discussion of pain. And I want to use it to prompt the next question. How do you cope? How does one cope with these chronic diseases, assuming that medication is not giving one a solution at this moment? Okay, Next slide, please. And with that, I'm moving into the second topic of cultural models and agency. Thank you. Yeah, move on. Okay. So what are cultural models? Cultural models is a concept that's shared between, I believe, psychology. I know psychologists in the US are using the language of cultural models. And it's widely leaned into by anthropologists and psychological anthropologists. So I have a rather longish quote here for you, but as I said, this is an educational forum, so I thought I would share. Cultural models are these processes of interconnected and widely distributed patterns of and for action that can be adapted and used by individuals to negotiate events in local worlds. They're models for and of action. They give us guidelines of what to do. The example I often use when I am talking to students is an example of a restaurant. So if one walks into a restaurant, opens the door, it's a restaurant one's never seen before. There are one starts scanning the restaurant for cues as to what one is supposed to do. If there is a giant counter and someone standing behind the counter and some sort of screen at the top of what to order that's also behind the counter, as well as tables, often what one will do is go first to the counter, assuming a script, a cultural model for a McDonald's-like restaurant. If instead one walks into a restaurant and doesn't necessarily see a counter anywhere near the door, but instead sees tables, especially tables that have tablecloths on them, that's a signal that we sit down and somebody is going to come to us and serve us food. Those are two different cultural models that we might have for how to solve the problem of what to do when we walk into a restaurant. So cultural models are guidelines, guideposts. They're widely distributed. We learn them as children of what to do to solve new problems. And chronic pain of these chronic autoimmune disorders, rheumatic disorders, is a problem to be solved. I have this ontological assault. The doctors can't solve my pain problem. What do I do? How do I navigate this? Next slide, please. So, we're only about, 40 minutes into the talk, and I'm finally getting to the title of the talk, Rethinking Agency. So anthropologists have come up with multiple different definitions of agency. The one in the center, agency, is a distributed capacity and potentiality produced by and a production of embedded, interdependent caring practices, relationships, and investments across space and time to fulfill and negotiate inescapable existence of fundamental needs. Oh my gosh, you really have to wish the anthropologists could write a little bit more clearly. But anyway, this was this person's definition. And in here, they're talking about the context of inequality. And agency is this potentiality, this capacity to meet needs within a context of inequality. And on the right, I have another one for you. Agency is understood as the capacity to realize one's own interests against the weight of custom, tradition, transcendental will, or other obstacles, whether individual or collective. And this one actually is by a scholar named Mahmoud, who has a lot of cachet in the United States. This particular definition is really about resistance, right? How is the individual standing up against doxa, against cultural norms, against agents of power? If you scroll down, and then there's a more neutral one. Agency refers to the social culturally mediated capacity to act. This is the one I tend to lean towards because it seems to me it's a little bit more wide open. It's a little bit clearer in the language. It's the capacity to do something. Can one do something to change a situation? Can one act? And this idea of agency is, I will argue, deeply embedded within the cultural logics of the United States. If you scroll down, please. So anthropologists really love this. I love the concept of agency. American anthropologists really love this idea of agency. I love it. I've used it multiple times. But the more I started thinking about it in terms of the experiences of people with chronic autoimmune diseases, I began to question and wonder, really, is agency such a good thing? Because every single one of these definitions assumes that agency is inherently good. It's something that should be sought. One should do something. Scroll down, please. And then if someone cannot act, if someone can't do something, in anthropology right now, the norm is to blame the structures that be, right? There are external structures that are oppressive and they're inhibiting action and people need to resist. But what if all of this assumes that people will want agency and take advantage of it at any time those powers, those structures are stripped away? But what if they can't? What if they can't? And that's the problem that I really struggled with when I am doing my work with rheumatic autoimmune pain disorder, people with these rheumatic autoimmune pain disorders. Okay, scroll down, please. So, within the United States, there is a pervasive, as I started to look into the cultural models for how do you cope, right, with chronic pain, these chronic pain disorders, how do you cope? I looked first at the public literature, right? What kind of culturally distributed model is out there? And things like Elizabeth Edwards, who ended up dying of cancer, but right after she was diagnosed, she, in a public 60 Minutes conversation, she said, you really have two choices here. I mean, either you push forward with the things that you were doing yesterday, or you start dying. If I had given up everything that my life was about, I would have basically started dying. I don't want to do that. I want to live. I want next year to look like last year. I'm going to keep on with my life. Okay. All right. Scroll on to the next one. And then this one, never give in, never give up. On the back cover of this bestseller, it says, the author, right, is bound to a wheelchair since the age of 17. And yet she skydives. She flies her own airplane. And by reading this book, you can learn how you can solve any of the world's challenges too. Yes, great. What if you can't? right? But this is the cultural model. This is the dominant model for how one is supposed to respond to a chronic pain condition in the United States. Scroll down, please. And I call this the John Wayne model. So it's a common cultural model in the U.S. By calling it a John Wayne model, I'm sort of signaling that I do not expect this to be a global model in any way. This is definitely an American aberration, right? John Wayne was a sort of cowboy, quintessential icon of the American myth of what the West was like. One should always do something, be very independent, overcome any adversity. You never back down. You never complain. You just keep going. And within medicine, people with chronic health conditions, some of them are able to do that. Please scroll down. So Christina, for example, and I write about Christina in one of the papers I reference, has Wegener's, I never can pronounce this one. She has Wegener's disease, okay? That's how the physicians typically refer to it. And it's treated by rheumatologists. It is a soft tissue disease causing autoimmune inflammation of the blood vessels, limiting blood flow, most commonly to the GI tract and the respiratory system. So she was in her 20s when I got to know her. She was an incredibly savvy patient. She was a single mother of a toddler. She worked full time. She was very sort of systematic in making very careful choices. She adhered to her medications. She kept careful notes of all of her appointments. She worked very hard not to depend in any way or be a financial burden in any way on her parents. She wanted to even take child support from her ex. And yet, she was constantly very conscious that with the medication I'm on, I have to keep an even keel or I'm done. I can hardly even get home from work. She was not going to stop working. She totally was control of her life all the time. The physicians loved her. She never once complained. Scroll down. And physicians seeing people like Christina or other patients who are able to do and follow the John Wayne model as a cultural model to respond to illness, physicians admire them. And they'll say things like, I've never met a patient like her. She doesn't let the disease phase her at all. She's amazing. She never complains. She never whines. This is talking about a different patient. Doesn't let the scleroderma slow her down. She's in a lot of pain, but she doesn't stop her from working or raising her child. Right? It is a cultural model that some patients are able to follow, and physicians reinforce it by admiring it. But not everybody can. Next slide, please. So, the John Wayne model, as I mentioned, is deeply embedded in this American ideology that doing things is associated with moral goodness. One has to be productive, to be active, in order to have moral worth, which I think you'll agree is a very problematic way of setting up a society. Very much the corporate hustle culture. So much that. Yes, absolutely. Next slide, please. So in this paper, I looked at Livia Poliani, who is Michael Poliani's child, and a brilliant linguistic philosopher of her own. And she did basically a study of the cultural grammars embedded within American society. And she argues that, and I'm reading it in the capital letters towards the bottom, which is how it's written in the book. Adults are individual people who know how to do what they must do. Sorry, that's a typo. Can do what they must do and do it. And adults must know and must be able to take it, withstand pain, and know that he has a future and that the future is better than the past. Always optimistic and very John Wayne-like, right? It's entirely embedded within a meritocratic society, that corporate culture that you were just referencing, and this compulsion to act, because if you can't act, you're not really even an adult, let alone a valuable contributing person to society. You see how problematic this could be for someone in chronic pain? Let's scroll down. Because if one is in so much pain that you don't have the energy to be productive and you can't engage in action, now what? Scroll down, please. So, next I'm going to talk about the suffering response. Scroll down. Oh, we've already talked about this ontological assault. So Christina was able to manage it, but Sarah, go ahead and scroll down, is not able to manage it. So Sarah, within the span of a year, was diagnosed with fibromyalgia and lupus. And she talked about how just over a year ago, I was Superwoman. I had it all and could do anything. She was in that corporate hustle culture. But because she got to the point where she felt like she was being electrocuted all the time, that's the level of her pain. She no longer could get out of bed. She could no longer do the dishes. She had to quit work. It had all kinds of negative consequences on the financial well-being of her household. And she couldn't do anything. She would plan for days to be able to make it to her doctor's appointments. That was sort of the best she could do. And then she would collapse for a week afterwards. Her pain was overwhelming. Scroll down. If the John Wayne model is the only cultural model available, and I argue that it is for people who have pain in American society, then Sarah didn't have another option. And yet she had to somehow get by, and I call it the suffering response. So it's a cultured response as a concept of understanding the realm of doing nothing, right? If a cultural model is a model for and of behavior, we don't have a model for not behaving, right? So I call it a cultured response. It's not ideal. And what's really striking is that every one of the patients that I worked with, even those who just couldn't do the John Wayne response, wanted to, right? That was the cultural expectation that they wanted to meet and just couldn't. And that not being able to meet it was in itself also oppressive. I argue augmenting their suffering that they were already experiencing because of the chronic uncontrolled pain. Scroll down, please. I was talking about visibility earlier. This is Sarah saying, I think the hardest part is that people don't see it. They look at me and they don't see that I'm sick. I can walk, I don't look sick. But they can't see that my nerves are raw, in constant pain. They can't see that my life has been turned upside down. Participants in my study in the US, we have placards. They're called handicap placards that people can put on their cars so that they get privileged parking. But if you don't look sick, instead, people would receive comments like, Why are you parking there? You shouldn't be parking there. You look fine to me. And all that does is, again, augment their suffering and remind them that they are not able to meet this cultural John Wayne-ish expectation. Scroll down, please. So disease is a physiological pathology, but illness, or one's experience of disease, is social and thus subject to social legitimation and or critique. Scroll down, please. And in looking at Christine as a case study and Sarah as a case study, Christine, who was able to do the John Wayne approach, when her disease was visible, say physicians who knew about it, they described her as heroic. Man, she's amazing, right? For her coworkers or people she might meet on the street for whom the disease was invisible, they just thought she was normal, right? Both of those are positively valenced. Sarah, who couldn't do the John Wayne response or John Wayne model, at best could be pitied. And she could only be pitied if she could figure out some way to make her invisible lupus, all that pain, visible. Otherwise, even her family members would call her lazy. Scroll down, please. Nisha, thank you so much for sharing that. I really appreciate that. And I am glad that this is resonating with you. I really appreciate you sharing that. It's so hard. And I also find it interesting that you're feeling the John Wayne model in your world too. That is one of my questions for you all as part of this conversation. So as we think about social responses to these disorders, to people who have invisible pain, people don't necessarily tell us what's going on. And remember, I'm just looking at a small segment of people with these chronic autoimmune disorders, but there are a lot of different pain disorders out there. And many of them are invisible. And people will make snap judgments, and those judgments hurt. They are barbs in one's skin. So Claire, whose stomach was always in pain because of her scleroderma, she's just a picky eater. Scroll down, please. Or Tammy, who has ankylosing spondylitis. Couch potato, lazy. Scroll down, please. Or John, who has RA, was told he's just not trying hard enough. People's comments are so unknowingly cruel sometimes. Scroll down, please. And Kirby was told he was just milking the system. Scroll down, please. So I want to talk about Kirby for just a minute. Kirby has been living with psoriatic arthritis since he was 7. It wasn't diagnosed. So for 50 years, more than 50 years, he wasn't diagnosed until he was in his mid-20s. It wrecked his GI system. He would be playing American football, and all of a sudden his knee would give out for no apparent reason, and he would have to be carted off the field. He wouldn't be tackled. Nothing would have happened. His knee just would have collapsed on him, and he thought it was something wrong with him until much later, and he was diagnosed. Scroll down, please. So Kirby told us, every single thing I do in my life is calculated in terms of how it's going to affect me physiologically and psychologically. Think about that for just a minute. Think about having one of these chronic pain conditions and constantly be thinking, if I have this cup of coffee, if I go on this walk to the corner to pick something up at the little corner store, what is the impact on the rest of my day or my week going to be because I do that? Scroll down, please. And this is a quote by Jean Jackson, just underscoring that pain is not merely a physiological sensation. It's profoundly cultural. It's profoundly social. It's profoundly emotional. Scroll down, please. Psoriatic arthritis, I touched on it before. Here are some images that if you are attuned to it, you can see it, but you can see how each one of these could very easily be invisible to someone who is not acquainted with psoriatic arthritis and some of the symptoms that people can experience. Scroll down, please. So our work with Kirby started with one interview, and then I found him such a fascinating a person that I asked if he would be willing to do ongoing interviews with me. Mitchell Singstock was a student. He's the one that's now a physician. He was studying neuroscience, so I was able to do something I had never done before with our conversations with Kirby, which for us was just fascinating. Scroll down, please. And that was really try to map out in the brain what's happening when people have pain sensations and trying to map out neurologically how that then is experienced physiologically, socially, and culturally. Scroll down, please. And this is what, working with Kirby, we developed as a model. So there's a background of constant pain, right? But then there can be something, say a twisted ankle, that has a heightened pain sensation. And that heightened pain sensation physiologically is going to trigger inflammation. It's also psychologically going to trigger cued memories of negative experiences in the past when one thing like this, a turned ankle, a collapsed knee, led to ridicule, embarrassment, a month of being on one's back. So it can lead to catastrophizing, which actually can heighten the immune response, which, when related to stress, which heightens then the inflammation response. And you can have this really strong negative cycle. Scroll down, please. And this I show you with a lot of hesitation, okay? Because every once in a while, and remember, Kirby has been living with this disease for 50 years, and he's incredibly conscious of what he's doing. Every once in a while, he is able to stop the process cognitively. He can't do it all the time. But every now and then, he is able to control his emotions, and instead of focusing on the pain and going into the catastrophizing cycle, he is able to say, yep, I just turned my ankle. I am going to sit down and relax and do something else for a few minutes, and then it'll be fine. And then he can sort of consciously push himself ever so slightly every once in a while into something more positive. Now, I say this with hesitation because this is so hard. He knows what he can do to have a positive impact. And even Kirby, who knows this and has been living with it for 50 years, can only do it some of the time. Scroll down, please. And now I'm going to get us back to our spoons. And I promise this is the last thing I'll talk about, and then we will wrap up. Okay. On a good day, Kirby told me he has about 14 spoons. On a bad day, he has 2 to 4 spoons. So what on earth does that mean? Scroll down, please. Scroll down. So a woman, Christine Mezzarandino, in 2003, is a patient with lupus. And she was trying to explain to a friend of hers in a restaurant someone else knows about spoon theory, what it's like to experience lupus. And what she did was say, imagine you have 12 spoons, and she gathered the spoons and then said, every time you do something, it takes one spoon. And you only have 12 spoons in your arsenal for a day. That's it. That's all you have to spend. You spend more than 12 spoons and you're in bed immediately. So you can imagine how quickly spending all of those spoons could be. And if you start with a smaller number on a given day because the pain is so intense, or one didn't get enough sleep, or someone's worried about something, right? The spoons become less. And then the ability to intervene in pain events is so much lower. So scroll down. Here is one example of what one could do with a spoon. So I would like you all to go back to your list. And you can use your own calculus for your list. But tell me how many spoons you have used so far today. Everything you did took at least one spoon. So getting dressed took a spoon, a shower took a spoon, each meal took at least one spoon. If you cooked it as well as ate it, that took multiple spoons. Attending this lecture and listening to me probably took 4 or 5 spoons. It's the end of the day, maybe it took 6 spoons. Figure out your number of spoons. Angelita, thank you so much for sharing. How are we doing on counting our spoons? Are you about done? Okay. Then if you'd scroll to the next slide, please. So these were my spoons for the morning. And remember, my day was much less than yours. My day, it's only 10:40 in the morning here. I wouldn't have made it to the lecture. If I had 12 spoons, I would have showered and gone back to bed this morning. Would not have been here if all I had was 12 spoons. And I want you to think about how many spoons, just throw out some numbers. How many spoons did you all have for today? 32, 34, 25, 37, 36. About 100. Oh my gosh. You really need this day to be over. More than 30. 38 spoons. Yeah. It takes a lot of energy just to have a normal day. It takes a ton of energy. And this, for many of you, you are living your normal day without chronic pain. Those spoons, those activities are so much more costly if you do have chronic pain. Scroll down, please. And you can skip the next one too. Just keep scrolling. There we go. And you can keep scrolling. I've already talked about that one. So if we think about Kirby and Sarah in terms of spoon theory, Kirby was able to be agentive because he still had spoons left that day when he turned his ankle. And he had years of practice of knowing what to do, but often he doesn't have enough spoons to do so. And Sarah's suffering response was not resistance. It wasn't agency. It was, how does one live when one wakes up every day and you have 1 to 2 spoons? That's it. That's all you have to spend. Scroll down, please. So the concept of agency assumes an abundance of spoons. Everyone has tons of spoons to spend. It's just figuring out how you want to spend them. But if people don't have enough spoons, agency is not even an option. And the theory doesn't account for that. Scroll down, please. Some days there just aren't enough spoons. Scroll down, please. And and these are my concluding comments. 1, the concept of agency is inherent in the concept of cultural models as defined as a cultural model is of and for action. The American cultural model for coping with disease is very agentive, it's very John Wayne, and it can decrease suffering if one can do it successfully, like Christina, or it can increase suffering if people want to be John Wayne, but they just don't have enough spoons. Spoon theory, as a couple of you, I'm so thrilled that that some of you had heard about it, can really help ground our understanding of the illness experience in empathy in ways that evade the judgments of social legitimation processes and challenge those social legitimation processes. And while agency, I believe the capacity to act in culturally meaningful ways is a universal. In different cultural contexts, there may be differently socially legitimate options for experiencing and responding to disease. I would really love to find out what those options are in India, though I understand that now, after this morning, that John Wayne is also live and well in operating in at least some parts of India. And finally, that more work needs to be done on chronic pain and rheumatic disease. All right, and those are my final comments. Thank you. You can keep scrolling down, and I'm going to open it for questions. I went a little bit over. I apologize. Thank you.
Thank you, Professor Hay, for your really interesting and enlightening lecture. We will now be opening the floor for questions. If anybody has a question, please feel free to unmute or type it in the chat box, and we'll be addressing them one by one. We look forward to an engaging discussion, so please don't hesitate to share your thoughts or queries. Soumya has a question.
Yes, good evening, ma'am. Good evening, Professor. It was a pleasure listening to you. I have a question. My mom is a cancer survivor. She had cervical cancer. And my father was a Parkinson's patient. He's no more. But while taking care of them, what I saw was my mom could cope up with the pressure of having an illness like that much stronger emotionally. But my dad gave up on Parkinson's quite easily. We lost him in a span of 3 years of he falling ill. Do you find that similar, because you're in the field? Do you feel women cope up with this kind of chronic illness and stress better than men do?
Oh, that is a really interesting question, and I don't have any evidence that would confirm that hypothesis. I'm really sorry to hear that your father really, it sounds like, struggled with Parkinson's and ended up passing away from Parkinson's. Parkinson's can be a very hard disease, and I am sorry to hear that. And congratulations to your mother for surviving cancer. Cancer is an equally awful disease, right? There are so many awful diseases. And I'm glad she was able to confront it. My question, great hypothesis, exploring. I don't know the answer. I would ask, might it have something to do with treatments? Because there are really good treatments for ovarian cancer, particularly if it's caught early enough. And Parkinson's, there really aren't a lot of great treatments out there for it. So does that play into one's, going back to that idea of feeling hopeless, does that play into feeling hopeless when confronting a chronic condition? I don't know.
But my mom accepted this very quickly. She saw my dad also suffering and also battled her own cancer. But that's what I saw, because I don't have brothers. We were three women taking care of my dad. And surprisingly, we all coped up very well with each other. Three women and one man suffering at home. So I felt maybe this is a trend across. So I thought you're the right person to ask that. But thank you very much.
It might also have to do with changing in social roles, right? So at least in the US, caregiving is very much part of the regular social role of women. And working is a socially legitimated role for men. And if men aren't able to do work, even if, I don't know if he was in retirement or not, if they aren't able to do that work, that social legitimizing work, did that potentially have a negative impact on his willingness to accept and move his way through the disease? I don't know.
Could be. Thank you very much.
Mm-hmm.
Nida ma'am also has a question. Yeah.
Thank you so much, Professor Cameron, for sharing your thoughts on how we perceive pain and the ontology behind it. I had a question from a perspective of, let's say, interaction of biomedical literature and qualitative literature that exists on pain. How much do you think our current language or discourse need to evolve or change to address pain of clients or patients who would come in for treatment? Like, for instance, a lot of times patients are often asked, can you rate your pain on a scale of 1 to 10? And that's objectifying it in biomedical literature, right? So how much do you think we need to change the discourse, and how could we go about it?
Oh, that's the $1 million question, right? So pain, for people who experience chronic pain, pain is not simply a scale of intensity. It is also an emotional scale. It is an exhausting scale. There's a difference between chronic achy, even intense achy pain, and incredibly sharp, I'm being electrocuted pain, and that 0 to 10 scale doesn't even come close. I've also had multiple conversations with patients, and this I find fascinating. It's something I want to publish, and I haven't had a chance to yet, but I will share my secret with you. Patients are particularly patients who have had the disease for a long time. They're very experienced with that pain scale. And they know that if they say they are at an 8, 9, or 10, the nurse and the healthcare provider, the doctor, are going to pay very close and quick attention to their pain. And if they say they're at a 4 or 5 or even 6, it's just like, garden variety pain. I'm not going to worry about it. And so I know patients who will say, who will come to me and say, yeah, really, my pain's at about 4, but it's really, I've had it for a long time. I want the doctor to pay attention to it. So I said it was at a 9. Or the reverse, right? Really, my pain is at a 9, but I don't want the doctor to tell me that I can't go on this trip that I want to go to. So I'm going to tell the doctor my pain's at a 3. So what then does that scale actually mean? It tells us, in my opinion, almost nothing objectively about the patient's actual experience. It tells us something if we want to statistically amalgamate it across all patients with a particular disease. Then I think it can be a really useful scale. But unless a provider says, you said it was an 8, tell me about that. Why did you say it was an 8? And even though I've been working with fabulous, amazing providers, I work with top-notch providers because frankly, only top-notch providers will let an anthropologist into their clinics, right? I don't think I've had any provider across my years of doing this research who said, you put down an 8. Tell me why you put down an 8. What does that 8 mean to you? If people started doing that, then maybe that objective scale would be more meaningful, in my opinion.
Thank you so much. And that helps in understanding how we can, just elaborate on the pain aspect a little better, not just limiting it to a scale.
Mm-hmm. I'd be interested if you find that useful.
I think I do. It's and it's coming mostly from a perspective of how I've in my research, at least when I've come across and met women who have been talking about pain, they're often just given the scale to essentially talk about their pain. And I work with women in perinatal and postpartum stages. So for them, enduring pain is a very common concept, right? Like that you're supposed to. So the scale is just a formality. Clinicians would come in, ask, how would you rate your pain? And then they'd walk away. So it's helpful to understand that, practitioners need to go a little beyond than just asking on that scale. Yeah.
In my opinion, yes, I think it would be helpful.
Do we have any more questions? Yes. Ma'am, you're on mute.
Oh, sorry. Thank you so much for a very interesting and insightful talk. In one of the earlier slides, I noticed you mentioned about the statistics, and surprisingly, 70%, 90% we saw were women who went through this. So, one of the observations I had was more on the lines of how agency in terms of expressing something that may be disturbing us or difficult for us, and how that plays a role in the whole symptomatology of pain or the experience of a chronic ailment or the development of it. I would like to know your thoughts on this.
It is an excellent question. You'll notice I intentionally skirted any potential discussion about gender within my talk. And the reason I did so is I am right now involved in a study that's looking at gender and to explore whether or not gender impacts the experience of psoriatic arthritis. So the short answer is I don't know yet. The hesitation is we know from most, not all, autoimmune diseases, ankylosing spondylitis is one of the exceptions, which is predominantly male. Most of the autoimmune disorders, rheumatic autoimmune disorders, skew towards women. The suspicions among physicians is it has to do with women's reproductive system and our immune systems that are associated with our reproductive systems. That being said, because of the history of calling women's disorders, particularly women's pain disorders, histrionic, and somehow not real because of that, I think there's a lot of hesitation to really dive into gendered differences for fear of slipping into it's not really real ideologies. Whereas I think all of the evidence is incredibly pressing, that that pain is very real. And I haven't seen really good biological evidence why, other than these hypotheses is connected to the women's reproductive system and associated immune responses, that it would be stronger for women than for men. It's a great question, though.
Thank you.
Yes, ma'am, you can go ahead.
Thank you all for your attention. I know it's getting very late where you are, so I just really wanted to say thank you all so much for joining us this morning and asking these really great questions, and Dr. Manusha for arranging all of this. I'm happy to answer more questions. I just want to free you because I know it's getting late where you are.
I think there was another person who
Yes,
raised her
Devishri.
hand.
Yeah.
If you have time, can we call them for a question?
Yes.
Devishri?
Yes, ma'am. Thank you. Ma'am, it was a great lecture. I really liked it. The spoon theory, that's the amazing part because it gave a lot of, it made sense so much because I'm working in a cancer ward and um, I'm working with a multidisciplinary team. So, as you said, the physicians they encourage people who tolerate more, and there are people from physiotherapy and all the walks in this medical field. So, telling them that that's not the right thing. Like they should acknowledge the pain. The spoon thing, it really made sense. They just say that you should avoid the thoughts about it, but I feel that even avoiding the thoughts cost you spoons. I feel it's a really hard work. So my question is, I just wanted to know, uh, you told about physical pain, emotional pain. I want to know what's your view on spiritual pain. I'm pretty sure it will reduce the number of spoons already available.
I'm sorry, you wanted to know about what kind of pain?
Spiritual.
Spiritual pain. Excellent question. I have no idea. It is a really important question, because of the context where I have been doing the research. I have not necessarily, we'll usually ask people to disclose their religious affiliation if they have any. But we have not had any conversations about spiritual pain. So it's a great question. I have no idea. I will say, and I should have said this in the talk, one of the reasons that the physicians applaud the patients that are able to do the John Wayne model is it doesn't make the physicians feel bad. Physicians are deeply, at least the ones I work with, they are deeply involved and care about their patients. They want their patients to do okay. They want their patients not to be in pain. And for a patient to walk in and be in chronic pain and the physician says, I don't have anything I can do for you, that makes the physician feel bad about them. So about themselves and sort of the limitations of medicine. And so if we look at it from that point of view, it's understandable why physicians might particularly want to see and applaud those patients that are able to do the John Wayne model, because then they don't feel, they don't notice the limitations of the discipline within which they have to work.
Thank you, ma'am. Thank you so much.
You're welcome.
We have one more question. Angelita Pinto has a question. She's also written it in the chat box.
Mm-hmm.
Yeah. She's asking, are there any papers?
Yes.
if she could read up.
So the Mhm.
Sorry, please go ahead. I think there's a network issue. Yeah.
Yes, so it's the Arc of Well-Being uh, paper that I wrote with Mitchell Singstock. Let me see if I can find quickly the link. Let's see. Okay, I found one link. It might not be the best link, but I will put it in the chat.
Thank you so much, Dr. Cameron. It was a wonderful session.
You're welcome. Thank you. Thank you for the question and for all of your engagement. I worry about the person who spent over 100 spoons today.
All right. So, if we have any further questions, we can collate them and we can send them across to ma'am, if that's okay. And you can answer them at like whenever you get time. So, before concluding, I have one request that there is a feedback form in the chat box for the participants. Please, like, we would appreciate your feedback on today's session, and it is already shared in the chat box. Also, that this filling this feedback form is a prerequisite to receiving the certificates for the lecture series. And one more small announcement for the next session, for the upcoming session on August 11th, we the timings have changed a little bit. So now the timings are 4:30 p.m. to 6 p.m. So now I'll just quickly give a vote of thanks. Before that, like ma'am, Mansha ma'am or Cameron ma'am, do you have something to say? Okay, I'll go ahead. Amazing. Cool. Thank you so much, Dr. Hay, for delivering such an insightful lecture. It was very thought provoking. I especially liked listening about the spoon theory, as one of the participants already stated. I will be using that personally. I will be borrowing that also. It's very interesting. And I I really appreciate that you shared stories of people that you've worked with, and everybody else's experiences, like looking at them, hearing about them, actually gave us a lot of insight, gave me at least a lot of insight. And as a health psychology student, it definitely helps a lot. It connects a lot of dots in all the courses that I'm doing. There's women's health, there was chronic illness, so all of that is actually making sense, and I could understand. So thank you so much. And your perspective on agency in chronic illness has also given us a lot, provided us with a lot of valuable ideas in the future, because you also said that we can work with in the rheumatology department. I'm sorry. So that is also like great job opportunities. And a heartfelt thank you to Dr. Surekha Chukalli, the Dean of School of Psychological Sciences, for her constant encouragement and guidance. I also want to share my appreciation and gratitude towards Dr. Sudesh NT, who is the HOD of our department, School of Psychological Sciences, for his constant, I mean, guidance, and for being here also, and for the support and the leadership that he has portrayed. I would also like to take this opportunity to thank Dr. Manjusha Warrior, coordinator of our department, and the session coordinator also. So thank you so much for your dedicated efforts in making this event happen. It like it was an amazing session. I really liked it, and my sincere gratitude to the organizing team also, all the faculty members and students and practitioners who have actually joined us in the session and made it happen and made it such a success. Thank you so much for coming here. We look forward to seeing you all at our upcoming sessions, and we continue to explore the broader dimensions of health together. So thank you, and have a wonderful evening ahead and wonderful day ahead, ma'am.
Thank you all so much.
Thank you. Okay. Thank you so much, Professor Cameron.